Hi, everyone. Welcome to today's Fireside Chat. We're going to be discussing something that I think a lot of folks are interested in, which is, well, on the highest level, it's about growing your brand, growing new revenue lines for a physician group or for a hospital or health system. And we're going to be doing it and looking at it in the context, in particular, of PT clinics. I'm joined with by a couple of guests here today who I'm going to ask in a second to introduce themselves, who can bring their perspective both from a orthopedic physician practice and from a large, well-known health system. Barb, I'll start with you. If you wouldn't mind just introducing yourself a little bit, that would be great.
Sure. My name is Barb Sack. I had 20 years as executive director with Midwest Orthopaedics in suburban Kansas City. And then as of January 1st, 2024, our group merged with the Kansas City Orthopedic Alliance. And my role now is Director of Systems Integration, which means I'm trying to head up an implementation of an EMR that the hope is will help me to make all 5 legacy groups act like they know and like each other. And so that's my challenge for the year.
It sounds like a no small challenge, but
Say a prayer for me.
Yeah. And Gary, if you wouldn't mind just
Sure. Well, Barb, I'm glad I'm here and not with your task ahead. My name's Gary Calabrese. I'm at the Cleveland Clinic, and my role as senior director is to oversee all the rehabilitation services for the Cleveland Clinic. So that would be physical therapy, occupational therapy, speech, athletic training, exercise physiology throughout the system. What I've been with the clinic for over 30 years and physical therapist for almost 40. We've had a rapid growth spurt. Probably that's been sustained over the last 20, 25 years. When I came to the clinic, we were sitting at a two bricks and mortar locations, and we've rapidly expanded that into several countries, several states, and sit at hundreds of locations now. But we're always looking at how to expand, where to expand, why to expand, and to try to learn from maybe some of the pitfalls that we ran into over the years, and to continue to grow the brand.
Fantastic. Great. Well, look, thank you. So maybe to kick this off, just at the sort of high level, what do you all see as a sort of top benefit of outpatient PT clinic expansion, and why this investment specifically? And maybe I'll start with you, Bob.
Well, I would say high level, it contributes to having a full spectrum of quality MSK, musculoskeletal care. Orthopedics and physical therapy are just inextricably linked. We've always been like right next to each other, as far as if you have a surgery, you're going to go to physical therapy. Maybe you're not having a surgery, but going to physical therapy could help you with whatever the challenges you're having right now physically. So it just makes sense. It's not grabbing onto that newest, shiniest thing that you're promised will bring you riches and be the best thing ever. It's just a natural partnership. And so I would say if we want to talk high level, that would be my answer.
Fantastic. Gary, what are your thoughts?
Yeah, I think Barb hit it on the nose. If we're talking about true team concepts of care, you have to have all the members of the team together. And I believe orthopedics and primary care orthopedics and primary care MSK physicians and physical therapy align nicely. And they do that at a high level for several reasons. One, from a physician side, we would desire consistency of care and consistency of outcome. And I think if you're not partnered or associated or closely tied to a rehabilitation and a therapy group, that variability in what your patients are going to receive post-care in your office will be detrimental to your ability to track your outcomes, to establish a patient base that is consistent and is your brand builder. So I think it's a natural partnership. We're fortunate where I am. We're all in one practice, so I have that luxury. Our physicians, our therapists, we're employed in one practice.
Right. Yep. Yep. Absolutely. Obviously, and Cleveland Clinic has used outpatient PT clinics to great effect, and there's even, I think, more planned, I think, coming in the future. Can you talk us through the how, understanding and mapping patient population needs and getting the clinics up and running actually works?
Sure. So what we like to do is, we believe our existing patient is our best patient and our best advocate. So what we consistently do is track where our patients come from, whether through zip code or survey analysis, and we try to. It's like a heat map where you try to pinpoint locations where you have volumes that you may not have thought you had volumes in, that are in outer circles or outer states that come to the facility for care. So we do a tremendous amount of data analytics on where our patients come from, what they came for, and then try to match like services close to home. Patients will drive, fly to come see a physician, and because it's a specialist and so forth. Physical therapy is a shoppable commodity. I mean, there's physical therapy on every corner of every city. So, I think one of the things that we look for is where are our existing patients, and we use our data and our internal systems to track all that. But then we also look at acquisitions. So the other way that we use data in expansion is acquiring hospital systems or physician practices in those same areas that the data is pointing us to. So if our patients are coming from there, are there providers or systems in that region that are of high quality that would give us a larger market share in an area that's not what you would consider in the core county system?
Yeah, that makes a ton of sense. Bob, PT clinics have been pivotal to your organization. What have been the most valuable outcomes so far, and how have those enabled your organization to succeed in its mission?
Well, to be just bluntly honest, we started in mid 2014 with PT, and we were trying to keep our physicians' incomes whole because, as everybody who works in healthcare knows, there was just this increasing administrative and regulatory burden that was making it harder and harder to collect every dollar that you did earn, and the reimbursement was decreasing. So we looked at other different things we could do. We had already tried the do more with less and be more efficient and all of those things, and we decided to try physical therapy, and it was working wonderfully. I would say that in 2016 we had a real epiphany, because that's when CMS rolled out CJR, which was the comprehensive, I think, joint replacement program. It was a a program that was dipping the toe into bundled pricing. And this was for total hip and total knee replacements. And the aim of it was to improve outcomes for patients and, of course, to help save money for the system. And that really opened our eyes to the value of owning and controlling our own PT, because if you did any kind of deep dive into how any of the bundled programs are structured, you find out that for those surgeries specifically, and I'm sure for many others, the majority of the cost to the system is in post-op care, including outpatient physical therapy, but also things like skilled nursing and so forth. What we learned, to our astonishment, was that we were so siloed that we just did a handoff. I mean, you're being discharged from the hospital, and now you're going to go to outpatient physical therapy, or you're going to go to skilled nursing and then outpatient physical therapy, whatever the specific situation warranted. But we learned that, as Gary mentioned, physical therapy is a shoppable commodity, and you don't know where your patients are going. It doesn't matter that much to you where they're going, as long as the correct orders get to them and they do what you expect them to do. But you find out just in shocking clarity that not all of them do what you want them to do. And they don't always follow all of your orders. And sometimes they do, but hidden in that 5-page note they send back to you is, and we think we should continue this for another 6 to 8 weeks. And the doctor doesn't see that part. The doctor sees what's their range of motion, what's their degree of flexion, all of these kinds of things that they're looking for specifically for their expectation of this patient's progress. And they've just signed off on 6 to 8 weeks more. And so we found that we really valued the fact that our physical therapists were very interested in doing exactly what we wanted them to do. And they would contact us and say, hey, we have this patient in common, and we would like to try this and that. They would contact us. They would talk to us. Whereas with other groups, they kind of hid it in the notes. And then at some point, I remember one of the doctors saying, why are you still in physical therapy? It's been 9 months. And they told him, well, they told me that you keep ordering it. And so anyway, it was quite an epiphany. But we have come to really value and believe that our patients get the best care the way we now have it set up and owning our own physical therapy.
Yeah, sort of plugging those gaps in care, and then the sort of care coordination that comes with that, right? That allows for ultimately better patient outcomes.
Exactly. I mean, all of the incentives in the system are set up in a way that incentivizes each of the different silos to maximize their potential profit. And that means you've handed them off perhaps to a skilled nursing facility. And we learned that patients coming back in 2 weeks for their post-op appointment to have their staples out, and they were doing stairs before they left the hospital. And when they come back, they're not. And they tell the doctor, well, the skilled nursing facility told me we don't do stairs until the 3rd week. And you think, what? Why is that? Well, it turned out that 21 days is how long the skilled nursing facility had allowed by Medicare for rehab for a given year. And that's exactly how long they plan to keep them. And so that is when they were going to start stairs, was on the third week. And we realized through this whole process that no, you don't need to be there for 3 weeks. You perhaps need to be there for 3 or 4 days, but you were doing great when you left the hospital, and we need to step up this rehab process.
Yeah, no, absolutely. And I'm guessing, Gary, you've seen the kind of same outcomes for patients and physicians as well.
Yeah, we do. Barb hit on a key topic, and it's that value proposition. The outcomes are really based on a consensus model of care and communication, and the value that comes between the multidisciplinary team is what drives that smooth transition of care. And when you interrupt that team's ability to discuss and talk and adjust treatment plans and programs based on the patient's progress and so forth, you introduce a variable that it gives you the scenarios like the skilled nursing facility. We've had the same experience, with the 21-day rule, and I think probably anybody in practice has had that experience, but it really brings home the point that the outcomes are based on the multidisciplinary approach in care paths, in consensus of care, in modeling, and in outcomes. And if we look to that data, that gives us our answers as to, are we doing things the right way? Are we going down the path? Do we identify red flags early enough? And if these red flags are identified, do they get into the right hands for assessment? And that all brings value. And I truly believe at some point, it may not be in my career, but at some point, the value-based system will totally drive reimbursement levels.
Yeah, I mean, it's coming slowly, but surely.
Slower than we thought, actually.
Yeah.
The total joint experiment was one of the first, the bundled, and the financial model of incentivization to drive the value actually had some success and is successful, but it didn't move the needle as much as we actually thought it was going to. It is progressing slower than we thought.
Yeah.
And I would say it was one of the few, it was the first time I've been in healthcare administration over 30 years, and it was the first time I said, wow, a good idea out of CMS. Who would have thought? But I really do believe that it does improve the care to have the management of and coordination of care. As Gary mentioned, it was probably not structured exactly the way you would want it to be for a long-term program. CMS programs tend to be something of a race to the bottom, so to speak, which was you have a target price, and if you can coordinate the care and have a good outcome at a lower price, then you will benefit from some of the in between, and that was incentivizing. But eventually, you get to the place where you can't go any lower without compromising the care. But now the target price is down. They kept lowering the target price. So, we went from CJR to BPCI, the same thing. And I do think there's value in it. And I agree with Gary that we're headed that direction. I hope we're headed that direction, because we clearly need to do something with the healthcare system, but there's probably a better way to do it for a long-term sustainability.
Right. Yeah. Yeah. I mean, I think, one of the things, of course, is how do you set these systems up, right? I mean, what would you say the biggest barriers to outpatient PT uh, uh, clinical success, and how can these be mitigated?
Yeah, I can start with that. Depends on what you're looking at it as a barrier. So you can have internal efficiency barriers like inaccurate coding, billing, the things that are crucial for the billing process to go through smoothly. I think one of the biggest challenges is patient retention, and there's a saying uh, of I forget where I read it, but you want this wow factor, this factor that says uh, you want people to say you wouldn't believe. So you want people leaving your office saying you wouldn't believe the care I got. You wouldn't believe my therapist is this or my physician is that. So I think patient retention and the word of mouth that comes with it is a barrier sometimes to practices that are focused on just throughput, just batch billing, just um, you know sprinkling in self-pay treatments that maybe have weak evidence, but they sell it. So I think that's one of the big barriers. And I think probably the biggest for us, we're a large department. We have over 1,400 clinicians in rehab, is probably burnout. We don't have high turnover, but we work really, really hard at making sure everyone is functioning at the top of their license, is professionally growing, and is meeting their expectations in the profession.
Yeah, yeah. No, I'm sure that's a constant effort.
Constant.
Bob, yeah, Bob, how about you? How about what have you found to be the biggest barriers?
Well, I have kind of a dual story there. We were very lucky in that when we started 10 years ago, um, we were, as I said, looking for ways of keeping the physician's income where it was and hopefully increasing. Um, and at the time, I was hearing from a lot of colleagues that they were getting rid of PT because it just didn't make any money anymore. And I learned that even though I'd been with my group eventually 20 years, it was maybe 10 years before that they did have physical therapy and got rid of it for the same reason. And so we went in as kind of a gamble, throwing the dice, and we had a great experience. And so that was something that really we've never looked back. Now, for a while, we couldn't do it because we were on a hospital campus and we could not have competing services with the hospital on the campus. Our physical therapy is across the street from us now. And with the merger last year, the biggest barrier right now, I would say, is that some of their locations are on the bad side of the state line, meaning they're in Missouri. And Missouri is the last holdout that doesn't allow for physician-owned physical therapy. And so we're working very hard to find ways to work with that or around that. But we also think that as we do more direct to employer contracting and bundled pricing, this gives us a real advantage in those areas that make the challenges seem small in comparison.
You brought up something which is, I think, really important to discuss, which is the profitability or lack thereof of physical therapy. And I think a lot of organizations look at physical therapy as, whether it be a hospital, health systems, or orthopedic groups as something that they don't necessarily want to own, or if they do own it, it sort of loses money. There's obviously costs in setting it up as well. That's not been your experience, I know. And could you speak a little bit to why you think that hasn't been your experience?
Sure. I've always been very active in the orthopedic executives groups and on the listservs and so forth. And so I always was watching and reading about their experiences. And what I came to realize is that I do a lot of things really, really well. And I'm pretty smart. I have no idea how to manage a physical therapy department. And it is totally different from managing and billing for a medical practice. And when they started talking about the number of units and how many, I couldn't even tell you. I thought, okay, what I know for sure is that I can't be the one doing this. I need to partner with somebody who does a really, really good job. And so now my job is to find the absolute best partner so that I can rely on them. And that was, we hit the jackpot there, thankfully. And so it has been profitable. It's been very profitable. After the first 60 days, we were profitable and have been profitable every month since then. And I was just looking last night at how much per partner it had brought in, just bottom line net dollars, and it was over $100,000, I think, in one of the last few years. So it varies, of course, but just depends on year to year and the volume and all of that. But it obviously has been very, very profitable for us. And physicians only have so much time. Everyone, we all only have so many hours in each day. And no matter how good an idea a physician may have, he's only going to get paid for what he does. And he's going to get paid for how many times he does it. And so he can't expand the number of hours he has in which to do things, but this allows him to get better care for his patients, more cohesive and better managed care, and it brings in more money. So it's a win all the way around for the patients, for the physical therapy, and for the practice.
Yeah. And you leverage a third party, which basically deals with all the management and headaches and reality of that.
Right.
So you don't really have to worry about that.
I always say that the vendors I love most are the ones I never have to think about. And the only reason I do think about them is because I do plan time to meet with them on a monthly basis. I get all of their reports, all of that kind of thing. But it's never someone rushing into my office with eyes as big as saucers saying, "Oh my God, you won't believe what's happening." It's never PT. They do that, but it's never PT.
Somewhere else.
Yeah. Barb, you brought up a great point about seeking out partners that are culturally aligned and have the capability of running part of the business model. And that is critical. And I think many physician practices, are under the impression it's easy, number one. And when they find out it's not, they want to dump it as quick as they can. So finding the right method to go about evaluating what your region, area, patient base needs is critical, and partnering with those groups that are either going to run the practice for you, partner in the practice, or manage the practice. Whatever is critical, because it is different. It is completely different.
It is completely different. And I felt lucky in that too, in that for the first few years before we contemplated doing this, I was watching all the other groups thinking, oh, if only we could, but we are on a hospital campus. And so I'm kind of interviewing groups all along, and I knew which group I thought, these are good people. These are people I trust, and they know that I can't do PT, and that doesn't matter to them. they just want to socialize, and we have a lot in common. And I just really like the way they act, and the way I can tell culturally we're very aligned, even though in my mind at the time, we can't do business, but we think a lot alike. And so it made that choice easier once there were some changes made saying you can have it and it doesn't have to be in the same building. And all of a sudden new avenues opened up for us.
Yeah.
I think it's choosing the right partner is obviously critical. That cultural alignment is such an important piece, because it's essentially an extension of your organization. Even if someone else is managing it, they're working with your patients. It's your brand, right, that's out there.
Right.
For Cleveland Clinic, obviously such a strong brand in healthcare, that can be no small consideration when you're deciding to bring a third party in to help you do something which obviously you guys could do yourselves. What was the thinking behind using a third party like PRS to do that?
Yeah, that's a great question. So when we started to look at how to expand outside of our 21 county in Northeast Ohio, and not leave Florida and all that out of it, but in Northeast Ohio, we have saturation in 21 counties, pretty dense saturation of medical services, and any of our medical services include all the multidisciplinary care. So depending on what the medical service is. So when we started looking outside of the 21 county and into neighboring states, we started to look at different models of branding and opening facilities. I already talked about the data analytics. We knew where our patients were, and they're outside those 21 counties. How do we get to them? How do we serve them? Because they're leaving the Cleveland Clinic with a referral for physical therapy, and they're going into another state or city, and we can't control kind of what they're getting. So we looked at really three things. We looked at, do we want to do it ourselves, which we could, but I can tell you in our system, it's a lengthy process. And you don't want to try to justify being the first service line outside of 21 counties, outside of 21C, without a partner. So if we were going to move in that direction, we would have to take our orthopedic surgeons, primary care orthopedists with us and open. And that's extremely time consuming. And in our system, would take years. We looked at practice acquisition, which we have done. And that's can get to be a relatively expensive process based on the practice. Some practices have a phenomenal book of business, and their bottom line is high enough that it demands top dollar. Or we could partner, and we could look for a partner to do it with us. And we quite honestly went through probably 4 or 5 different company models, some national, some local, because there's local private practices in these areas that are of high quality. And we looked for that cultural fit. And what we wanted to do was to assure that our brand, when the Cleveland Clinic is on a building, that the services in there would be, would equal what they would receive in 21C. And we settled with the decision to say we're going to partner and we're going to do it through a management agreement. And I had known a couple of the individuals in PRS for quite some time over the years through some of my physician colleagues, and we reached out, and so far we haven't opened our first office yet, but it is really, really close, and it's going to be successful. I'm confident, and it's a shared risk model, and that makes it a little bit easier at the administrative level to say, look, we're in a shared risk model. This is the format, this is the structure. We believe in the group that will be managing, and we'll have input on qualifications of the staff and how they're evaluated and things like that, which is what's ultimately so important for us.
So you're able to be flexible, specific to what matters.
Very flexible. And that's a great way of putting it. They really individualized, and I don't know what other facilities have, but I can tell you that they met every ask that we had that was reasonable, and we're very pleased.
Yeah. I think also, and also the capital costs, right? I think they take on a lot of the capital costs, right? Which is not a small thing. Any organization, practice, health system, you've got lots of asks on that capital,
Sure.
and lots of places you can deploy it. And if you can deploy, less capital in a place and still be able to build something, that's obviously, I'm sure, makes it more attractive.
Right. The capital light model and the shared risk really kind of made it a little bit easier to forge forward together. This will be our first office. Like I said, I'm confident the structure and the model will be very successful in many, many more locations.
Yeah. Well, I think this is probably also why Barb's experience has been strong, because at the end of the day, they have incentives to derive revenue, right? To look after your patients, to do all these things, but also make it and do it profitably, because that's their business, right? So it means that you have a far higher probability at the end of the day of making money from this, as opposed to just being a sort of loss leader. While it's important to look after your patients, it's also important to make money.
Right. I've been very lucky with the guys I've worked with, the physicians I've worked with. They feel very strongly that they know that healthcare is expensive. They know that there's all kinds of problems with it. They don't want to be a cause of rising healthcare costs. They would like to feel like they're a part of the solution. But at the same time, they are not just independently wealthy and doing it out of the kindness of their hearts. They might, if they could, but they are not interested in being long-term philanthropists, and just they do need to make money from it.
Yeah. There's nothing wrong with making money, delivering a service. I think one of the things also that's also very constant in healthcare, and I think life generally, but particularly in healthcare, is change. It's like one of those constants in life. In fact, if anything, to me, and I'm sure to you, it feels like the pace of change is just faster and faster. Technology, AI, all of these things, societal changes. What steps are you both taking to continually monitor clinical success and iterate in the context of what we're talking about here, as the market shifts, the external market shifts, and all the regulatory things shift?
Yeah, I think that we have to shift with it, depending on you don't want to make change abruptly, and ours kind of drips with a lot of discussion. We don't jump into fads, and I think it's important that you stay with the basic premise around musculoskeletal care, and then you add bits and pieces to it. and you may take other pieces away. New technology comes along. There's always some new device that is the next second coming to sliced bread. You have to be careful with those kind of practices, and let your competitors spend that kind of money, and it probably will fizzle if it's not legitimately contributing to outcome. I think you have to embrace curiosity, and that curiosity should be matched to your patient practice. And just doing the same thing, with every patient all the time, you'll be out of practice, fairly quick. So I think always be curious. Don't change too quickly. Don't jump on any bandwagons, and add the pieces that make sense for your practice, because some may make sense for others, but not for your specific practice.
Yeah,
Well
that's good
said.
advice.
Well said.
How about you, Bob? What are your thoughts on this?
I think that Gary's just hit on pretty much every aspect. You want to be sure that you are keeping up with the times, so to speak, and that's another place where the right partner makes not just makes a lot of sense, but it's critical to have the right partner. Because for me, just keeping up with United Healthcare and Blue Cross and Cigna and Aetna, I mean, I can't keep up with all the newest things in physical therapy. And so when we do meet monthly, they may tell me, this is a new thing that we've been watching for a while, and we want to introduce it in here slowly, or perhaps we've got our therapists are specializing. They're taking special courses, perhaps in TMJ, believe it or not, things like that. There's a postural institute that one of the therapists was doing not just some education at, but teaching. So different specialties amongst the different physical therapists, making sure you're connecting the patients with the right provider. It's not all generic. So keeping the high quality care front of mind is going to always work out for everyone best in the end.
Yeah, I mean, having someone who's sort of on the cutting edge watching that, right, and has the scale, because obviously running many different clinics around the country, looking at the latest things, evaluating them, where it makes sense to bring them into other groups and say, hey, this is working here, or this is what we're seeing, gives you another, I guess, set of eyes that's highly believable on, what you should be thinking about next, and obviously gives you the decision, or the physician's decision to say, yeah, we should do more of that, or we should try this, right? And ultimately that benefits your patients.
It definitely expands your bandwidth too, your ability to be looking at different things.
Yeah, for sure.
Yeah, Barb hit on something there that's critical, and don't have blinders on to other service lines and specialties. One of our fastest growing in our musculoskeletal offices, quite honestly, is vestibular care, and lymphedema now, and pelvic health. And it's still all related to core training, exercise, and some other aspects, of tissue management. But those are areas that probably for the next 20 to 25 years with the baby boomers is going to be a needed treatment, service. So try not to just isolate, oh, we only take care of left knees. It really is a broad spectrum, because that's how the patient's looking at you. They're looking at you as their medical professional, their physical therapist. and
For
their physician.
musculoskeletal care. It's not,
Yeah.
that's why we really have tried to change our thinking on, we're not just orthopedic care, we're musculoskeletal care. We
Right.
have physiatrists, we have physical therapy. We want to take care of the whole patient with their musculoskeletal care. It's all related. And that includes a number of different specialties, and that's what the patient really needs and wants.
Yeah, multidisciplinary approach essentially is what you're talking about, which is what's critical to getting the right patient outcomes. And it seems like you're both violent agreement about that, which is great. To wrap this up, I mean, I'd love to ask both of you for a couple of pearls of wisdom, right? 2 or 3 things, pieces of advice you could give listeners who are coming to this session, thinking about PT clinical expansion and whether that might be right for their organization or not. What are the 2 or 3 things that they should be thinking about first? Bob, I'll start with you.
I would say the first thing is to know what you don't know, because as Gary pointed out, physicians tend to think it's easy. Just add it on. And our jobs tend to be to make physicians think that everything is easy. It will seem to them as if it's easy. That's part of the job. But know what you do know and what you don't know. Remember that culture and high quality, that's what's going to ultimately get you where you want to be. And just keep an open mind about all of it.
I would echo that. I would say that do your homework. Are you looking to just serve your existing patient base? Then find a partner or design a structure that suits that need. If you're looking to impact market share, and to do that, you have to expand. Then you have to have someone who can do that with you, or that you have the capability of doing that yourself. I would say the cultures have to align, as Barb said, and the partner that, if you choose to go that route, is critical, and that has to be in alignment, or there'll be a disconnect with the patients.
Well, both of you, thank you so much for sharing these insights with us and the audience today. I think they are super helpful for people thinking about this, or perhaps who haven't been thinking about it, as a great roadmap of where to start and ultimately what it can deliver for their respective organizations. So thank you so much, both of you.